Severe multifactorial cutaneous leukocytoclastic vasculitis. Leukocytoclastic vasculitis is an immune complex-mediated vasculitis of the small vessels. The disease can result from medications, autoimmune diseases, acute infections, or be idiopathic. LCV can present with cutaneous manifestations seen in 30% of patients, and the rash is often found in the lower extremities. Here, we describe a case of severe, widespread cutaneous leukocytoclastic vasculitis. A 43-year-old female with a past medical history of hypertension, hypothyroidism, anxiety, and depression presented with a complaint of erythematous macular rash over her ankles. Patient lives with her daughter, 2 dogs, 1 cat, and a new pet rabbit. The patient had an upper respiratory tract infection 2 weeks ago before presenting, for which she took ibuprofen and Mucinex. Her URI was followed by a recurrent urinary tract infection, for which she took Macrobid and Bactrim. She stated that a small lesion began on her leg after taking ibuprofen, which progressed to multiple scattered lesions. The patient was admitted briefly, prescribed steroids and clindamycin for her rash, and discharged. Subsequently, the rash developed into blisters and rapidly progressed, requiring admission. Biopsy revealed leukocytoclastic vasculitis. Workup for possible etiologies was done. The patient was ANA positive with elevated rheumatoid factor. She tested positive for Mycoplasma IgG but negative for IgM. CCP, ANCA, double-stranded DNA, complement 3/4 proteins were all within normal limits. She tested negative for hepatitis B, C, cryoglobulins, HIV, RPR, cryptococcus, COVID, and her blood cultures were negative. The patient was treated with IVIG, rituximab, Solumedrol, and her rash improved significantly. In the results section, you can see a series of images showing the patient's rash during the course of her admission. Images 1A through 1C represent the progression of her vasculitis from her legs to her arms, as well as her abdomen, respectively. Figures D through F show the severity of the disease. You can see an eschar in figure D. You see severe blistering in E, and then necrosis of the skin in F. The most common causes of LCV are drugs and infection. In our patient, her likely offending agent is thought to be ibuprofen, but could be multifactorial secondary to her recent infections as well. LCV should be suspected in any patients with new onset skin rash, especially with a recent history of infection or medication use. Given that clinical manifestation of LCV varies from asymptomatic to life-threatening systemic disease, early intervention and workup should be started depending on clinical presentation. The confirmatory test is a skin biopsy. Though other immunological workups are needed to rule out other causes like HIV panel, hepatitis panel, ANCA, ANA, rheumatoid factor C3, C4, and other related tests as explained in our case, in most cases symptoms resolve on their own with supportive care and offending agents discontinued. Some patients may need antihistamines or steroids. However, in severe resistant cases like this patient, IVIG, immunosuppressive steroid-sparing agents, and or monoclonal antibodies can be used if needed. Physicians should recognize the correlation between new onset rash with recent medication use like NSAIDs, and workups need to identify LCV. Furthermore, patients should be educated that it could take weeks to months for the rash to resolve. Finally, in figure 2, we see an image. This is the patient's vasculitis in her lower extremity, approximately 1 year from her initial presentation when she was admitted. Thank you.